Systemic sclerosis. Systemic sclerosis is actually diffuse fibrosis of the skin as well as the internal organs. So there is diffuse fibrosis of skin and internal organs that is seen in systemic sclerosis. Women are affected more as compared to men, and also the disease appears in between third and fifth decades of life. There are two main forms of this disease. First one is cutaneous, that is, it affects skin, but it least likely affects the internal organs. So it presents as hardening of the skin of face, neck, and peripheries of the arms and legs. So peripheries of the arms and legs are affected, face and neck are also affected. So when there is fibrosis, then there is hardening of the skin. Furthermore, you can also see Raynaud's. When there is hardening of the skin, then the blood flow to the digits is also decreased, and you will see Raynaud initially. Then there is a severe form of this cutaneous systemic sclerosis, that is CREST syndrome. It is characterized by calcinosis cutis, that is calcium deposition, Raynaud's disease, esophageal dysmotility, that is when there is esophageal fibrosis, then the motility in the esophagus is reduced, due to which you will observe GERD in such patients. Then there is sclerodactyly and telangiectasias. Furthermore, in this cutaneous disease, you can also see bowel hypomotility because of fibrosis, and due to this bowel hypomotility, the bacterial overgrowth starts. Due to this bacterial overgrowth, you will see that there is malabsorption, and the patient presents with constipation alternating with diarrhea. Furthermore, when there is severe bowel hypomotility, then it can result in bowel distension, and bowel distension can lead to bowel rupture. So this is all about cutaneous disease. Then there is diffuse disease. In diffuse systemic sclerosis, as the name shows, it starts with polyarthralgia, weight loss, and skin thickening. It is diffuse skin thickening. It involves all the parts of the body like trunk, face, neck, and limbs. Furthermore, there is non-pitting subcutaneous edema. Non-pitting subcutaneous edema is seen in diffuse systemic sclerosis. You will also see telangiectasia, pigmented areas of the skin, and also areas of the skin where there is depigmentation. Pulmonary fibrosis occurs that leads to development of the pulmonary vascular disease known as pulmonary hypertension. Pulmonary hypertension develops secondary to this pulmonary fibrosis. Furthermore, pericardial effusions, that is fluids around heart block, and right heart failure develop. This right heart failure is due to pulmonary hypertension. Right heart failure is due to pulmonary hypertension. Then if we come to GIT, then there is decreased motility, obstruction, intestinal distension, gastroesophageal reflux disease. You will see these all features in diffuse systemic sclerosis. And there is a condition known as scleroderma renal crisis. This is a condition in which there is intimal proliferation of the smaller renal arteries. When there is intimal proliferation of the smaller renal arteries, then this scleroderma renal crisis occurs, that is associated with severe hypertension. If you want to diagnose through labs, you can clinically diagnose this disease, but if you want to diagnose this disease through labs, you will do CBC and you will see anemia. Anemia is mostly due to, because in this scleroderma renal crisis, you can see that there is intimal proliferation of the smaller renal arteries that result in severe hypertension. There is mechanical damage to the red cells from diseased small vessels that leads to microangiopathic hemolytic anemia. Microangiopathic hemolytic anemia. ESR is usually normal. ANA is almost positive in all cases, while anti-SCL70 antibodies are present in the diffuse disease, and anti-centromere antibodies are present in the cutaneous disease. So, in 80% of the cases of diffuse disease, anti-SCL70 antibodies are present, while in 20% of the cases of limited disease or cutaneous disease, you will see anti-centromere antibodies are positive. Furthermore, anti-RNA polymerase 3 antibodies may be positive, and these are associated with the cancers like breast cancer, etc. Like breast cancers. So solid organ cancers are associated with this anti-RNA polymerase 3 antibodies that lead to systemic sclerosis also. Treatment. So the treatment of this condition is, you cannot treat systemic sclerosis, but you can treat the manifestations that are seen with the systemic sclerosis. For example, for Raynaud's, you will give calcium channel blockers. For example, nifedipine 30 mg tablet. For skin disease, you will give methotrexate, especially when there are polyarthralgias. Then methotrexate is preferred. It is given once weekly. While if there is skin disease and there is pulmonary involvement, you will prefer mycophenolate mofetil. You can give, in renal disease, you will give ACE inhibitors. You can also give ARBs, but ACE inhibitors are initially preferred, and the ACE inhibitor that is given mostly in this condition is captopril. 25 mg given 4 times a day. In GI disease, for GERD, you will give PPIs. For decreased motility, you will give metoclopramide. While for bacterial overgrowth, you will give antibiotics like rifaximin. In case of lung disease, we will give mostly mycophenolate mofetil or cyclophosphamide. That these drugs decrease the rate of progression of disease, that is fibrosis is decreased. And if pulmonary hypertension is developed, then we can give phosphodiesterase PDE5 inhibitors like sildenafil. We can also give endothelin antagonists. Endothelin antagonists are bosentan, etc. Bosentan, ambrisentan, macitentan, etc. And you can also give prostacyclin agonists. Especially in refractory pulmonary hypertension, you will give prostacyclin pathway agonists, and these are epoprostinol, treprostinil, iloprost, and selexipag. Furthermore, the prognosis of this disease is, comparative to other diseases like SLE, prognosis is good. That is, 10-year survival is 70%.